Hey guys, welcome to the Module 6 exam review video, part 2. For this one, we're covering chapters 16 and 17, which is respiratory and cardiac emergencies. So I don't plan to review all the anatomy and physiology again, but I want to highlight for this exam you want to be familiar with dividing what is in your upper airway versus what is in your lower airway. We also should be familiar with the normal respiratory rates of different age groups at this point. More importantly, we need to be able to identify lung sounds or at least know what each lung sound is describing. So as we get into the pathophysiology, we start talking about different treatments. One of the biggest factors is auscultation of lung sounds. And whatever sounds you hear, whether it's wheezing, rhonchi, crackles, or stridor, we need to know what that means so that we know how to treat it. And here we are highlighting the terms of hypoxemia and hypercarbia. Just recall that hypoxemia means that there is not enough oxygen in the bloodstream, so that equates to an SpO2 less than 94%. And hypercarbia is just a state of having too much carbon dioxide in the bloodstream. The one we're focusing on is hypoxemia, which could lead to cardiovascular failure and hyperperfusion. So when we talk about respiratory distress, you all need to be familiar with signs of worsening and signs of improvement. So just to kind of highlight here, if you have an increased pulse rate or you are starting to breathe faster, having more labored breathing, or you are starting to become cyanotic, those are all signs of a worsening condition. Normally when we exercise and we get ourselves worked up, we start to normalize when we slow down and our breathing becomes more regulated, becomes more controlled, and we're not using as much accessory muscles. As you guys read your test questions, you really need to pay attention to the keywords of what we're asking for. So you all have already experienced different scenario-based questions where we give you a patient presenting with either, respiratory distress or respiratory failure, and, learning how to dissect these questions for those key terms is equivalent to how we assess our patients in the field. So for example, if we walk up on scene and we are trying to assess someone's breathing, we're trying to make sure that they have the adequate rate and volume and see if the patient is compensating or not. If they're in the tripod position, they look like they're working hard or they're becoming cyanotic, these are signs of a patient who is not able to compensate on their own. And so biggest takeaway here is to administer oxygen to maintain an SpO2 of 94% or higher, and we can also consider CPAP if we have to. If you're reading the question and we are describing the patient as having poor chest rise and fall, or they have shallow breathing, or any other terms that describes respiratory failure, that they're not moving air very well, then we're going to drive this point over and over that you need to assist these patients with ventilations. I don't care, what you try to describe or see in your head as what shallow breathing looks like. When we describe shallow breathing on our exams or in the NREMT exams, we're talking about a person who is just not adequately moving air well. If we're describing a patient who is in respiratory arrest, we're talking about a person who is not breathing at all, or they're having a cessation of respiratory effort. So as you can imagine, if someone isn't breathing, they're going to die very soon afterwards. So we need to make sure that we are prompt in immediately opening the airway and then providing bag valve mask ventilations. From this slide on, I'm going to be describing a bunch of conditions that can cause respiratory distress. And so there's a lot of them that we cover. For most of them, the management is going to look very similar, but try to keep up with the details. On this exam, we do need you guys to be able to differentiate or know like the differences between some of these issues or conditions and how to differentiate from one versus the other. And so the first one on this slide, we're going to talk about COPD, obstructive pulmonary disease, and it's divided into two pathophysiologies. We have one called emphysema, and the other one is chronic bronchitis, which I'll talk about later. So emphysema is when your lung tissue loses its elasticity. We've got so much damage within the walls of the alveoli that it's become scarred. It's not really producing surfactant to help it stay lubricated, and therefore we don't have enough gas exchange occurring between the walls of the alveoli to the capillaries that surround it. Um, we used to describe these patients as pink puffers, and that's because as they retain CO2 due to that lack of gas exchange, it causes them to have a flushed appearance. You'll also see them kind of purse their lips and do like a slow exhale where they're basically generating their own physiological PEEP. And that's to help keep their alveoli open and so that they can recruit it more easily on the next inhale. We don't really go by the term pink puffers anymore because most smokers or most people with COPD, emphysema don't always fit that description. But we still kind of use it in a teaching aspect to give you an idea of physiologically how this patient is presenting. The other branch within COPD is chronic bronchitis, and that is when you have the chronic swelling and thickening of the bronchi and bronchial linings. And so this is usually associated with smoking, and we have a lot of damage to the bronchi and bronchioles where they're always producing mucus, they're always inflamed. And so with that narrowing of the bronchioles, we don't have as much airflow coming in. So this is associated with the term blue bloaters, where your patients are cyanotic in appearance, and they tend to have this this buildup of fluid or retention of fluid in their bloodstreams, and so they get that swelling look. More often than not, the hallmark sign of chronic bronchitis is that productive cough. Some might call it like the smoker's cough, and again, these patients are going to appear cyanotic in color because they're not getting enough oxygen in. And as we're managing patients with COPD, we're going to follow the same guidelines as any patient suffering from difficulty breathing, where you're going to provide supplemental oxygen. What we're trying to highlight here in this slide is that many COPD patients can develop a hypoxic drive. So if you remember from Module 2, we talked about how everyone or most normal healthy individuals breathe through the hypercarbic drive, where our ventilations and breathing is stimulated by the amount of CO2 in our bloodstream. We have the hypoxic drive as a backup, and COPD patients, after years and years of retention of higher CO2, their hypercarbic drive is not as sensitive anymore, so it becomes dulled, and therefore these patients will rely on the hypoxic drive. So it's important that we maintain an SpO2 between 88 and 92% if that is their normal. And we may want to consider the use of CPAP if they're really struggling to get air in due to chronic bronchitis or emphysema. I will mention that over-oxygenation can be detrimental to these patients because once we go above their normal SpO2 range, you're now kind of training their body that, hey, we have enough oxygen, we don't really need to, ventilate as often, and then the body isn't going to recognize the changes in carbon dioxide. So biggest takeaway here, maintain an SpO2 that is normal for COPD patients due to their hypoxic drive. This slide I'm just having to illustrate the differences between emphysema and chronic bronchitis. You can see with emphysema you have destroyed alveoli, and that's going to decrease the surface area of gas exchange. Whereas with chronic bronchitis, you have more so mucus plugs and inflammation in the bronchioles that's preventing good airflow into the alveoli. Next up, I'm going to talk about asthma, and you may kind of see that asthma has some similarities to chronic bronchitis, where we have swelling and mucus buildup in the bronchioles or the lower airways, but asthma is due to increased sensitivity of those airways, and it could become reactive to allergens or any kind of dust particles or stress-induced, exercise-induced. Anyone who has asthma could probably tell you a various list of reasons that could trigger an asthma attack. But when an asthma attack, an acute asthma attack occurs, we're going to see bronchospasm where those bronchioles start to shut really tight, and we have edema of the airways. So this could be called status asthmaticus, and if it's presenting, you have a life-threatening situation. Here I just snuck in another slide to illustrate, the severity of all that mucus accumulation and the swelling of the bronchioles and bronchus. So with your asthma patients, again, we want to manage their ABCs, give them enough oxygen to maintain an SpO2 of 94 or higher, and we want to allow sufficient time for the patients to exhale when providing any positive pressure. Here we're going to highlight that last item on the list is the beta-2 agonist. So hopefully you guys remember from module 4 when you kind of reviewed your drugs that your beta-2 agonist is going to be your albuterol treatments. One thing we want to remember in choosing a beta-2 agonist is what lung sounds would you have to hear. So if we have narrowing of the bronchioles or swelling and mucus buildup in the bronchioles, that should produce wheezing. Therefore, if you perform your patient assessment, we want to listen to lung sounds before we jump to any treatment. And if we hear wheezing, then that's kind of our go ahead that we do in fact need a beta-2 agonist or albuterol. Next condition we'll talk about is pneumonia. So pneumonia is whenever you have an infection in the lower respiratory tract. Typically, we see the infection occur inside the lung, and this is going to lead to ventilation disturbance, poor gas exchange. But how do you know if it's pneumonia versus anything else? So since pneumonia is due to an infection, you'll typically see signs of fever or general malaise. If you ever listen to their lung sounds, they may have a lot of mucus production. And so the key lung sound here is you may present with rhonchi, your patient is febrile, and they're having trouble breathing. Since pneumonia doesn't always affect the entire lung or both lungs. It can affect just one singular lobe. You may have diminished lung sounds in one side or one portion of the lung, and the other side may appear clear. When caring for a patient with pneumonia, you should take some supportive measures for their fever. Like if they are extremely febrile, we don't want to heat them up even more. We might want to, take some of extra blankets off if they have any, or make sure that the heater isn't on because we want to keep these patients at a normal temperature. Otherwise, just do what you can to maintain their oxygen above an SpO2 of 94%. On this slide, we're talking about there's not usually bronchoconstriction associated with pneumonia. Therefore, you shouldn't hear wheezing, and therefore you don't really need to use albuterol or any other beta-2 agonist. Next condition, we're talking about pulmonary embolism. And so this is the situation where you have a clot that is blocking the pulmonary arteries. So we have a few things that we like to highlight as risk factors that increase the risk. And we talk about deep vein thrombosis or a history of deep vein thrombosis, or if your patient is sitting still for a very long time. A lot of questions on the exam or the NREMT exam likes to highlight a patient that was sitting on a train or in the airplane for several hours, like if they had a flight back from Europe and they just haven't been moving. The third one I'll highlight is females that are on the use of birth control, and then again having some long periods of immobility. Pulmonary embolisms are pretty life-threatening. This is a slide to just kind of demonstrate how big those clots can get. And so, this is in an autopsy where they pulled out these giant chunks of blood clots that were in the pulmonary arteries. So you can see if you have a clot that large in your pulmonary blood vessels, there's no way you're going to have any blood flow through that. If you're trying to ascertain if your patient is having a pulmonary embolism, they're going to have in the sudden onset of unexplained dyspnea and chest pain. You're going to see signs of hypoxia with normal breath sounds, and they're going to be able to move air well. So what we are looking for is their history. You're going to have to do a thorough history, and you're going to want to see a physical assessment of their lower legs. If they're showing signs of deep vein thrombosis, or they tell you they have deep vein thrombosis, or they explain they've had a recent surgery or they've been sitting, still for a very long time, that should increase your suspicion that maybe you're dealing with a pulmonary embolism. Other than recognizing that it's a possible PE and transporting to the hospital with the appropriate facilities, you just want to make sure that the airway is open, administer oxygen to maintain an SpO2 of 94% or higher, and that's about it. All right, next up, we'll talk about acute pulmonary edema, which is a very popular subject on the exam and on the NREMT exams as well. When we say pulmonary edema, we are saying that there is swelling around the pulmonary blood vessels and the lungs. And so with that excessive fluid, it's going to collect between the alveoli and the pulmonary capillaries, and therefore gas exchange is impaired. So the life threat here is that your patient is becoming hypoxic because of the fluid disrupting gas exchange. As the fluid builds up around the spaces, it could invade the alveolar sacs, and now you have a patient who is really drowning themselves. So the chief sign that we're looking for is when you auscultate the lungs, what do you hear? And if you hear crackles, which is described as, the popping of little air bubbles inside the lungs, that's due to the air forcing its way into the alveoli and then it's trying to push that fluid out the way. That's when you know you're dealing with pulmonary edema. The really complicated issue here is that as your patient becomes more hypoxic, they're going to become more anxious and restless, and they might even be combative and not be able to follow directions very well. When you are treating a patient in acute pulmonary edema or heart failure, we want to make sure the patient is sitting in an upright position, and that way the fluid isn't diffused throughout the entire lung, right? If we sit them upright, then all of that fluid can, sink to the bottom with gravity, and therefore you have more of the lung that's actually able to work and exchange air. You want to administer oxygen, obviously, and this is where we say that CPAP or positive pressure is very beneficial because with positive pressure, you are able to force those alveoli open, and then that pressure is going to help push the fluid back out of the alveoli and into that space. And this way, we can have a little bit better oxygenation as gas exchange is able to occur again. Next up is the spontaneous pneumothorax, which is the sudden rupture of visceral lining of lung or the partial collapse of a lung. As you can imagine, if we have a rupture inside the lung, that's going to impair gas exchange. And we have risk factors including smoking, COPD, or some connective tissue disorders. We divide spontaneous pneumothorax into two categories where we have primary spontaneous, where the patient had this occur and they didn't even have an underlying lung disease. And secondary spontaneous pneumothorax is when there is an underlying lung disease. With a spontaneous pneumothorax, you're going to have a sudden onset of shortness of breath without any obvious evidence of trauma, and you will have decreased breath sounds to one side, unless you're unfortunate enough to have a spontaneous pneumo on both sides, and both sides will probably be diminished. When they're seated, you will have absent breath sounds in the apex or the top of the lung where these spontaneous pneumos typically occur. And I kind of want to highlight that on the exam or for most registry questions, we like to describe a certain demographic that is, usually high risk for spontaneous pneumos, and that's going to be your teenage males or your young adult males that are tall and lanky. So the idea is that they grew up too quickly, and as they stretched out their chest wall, it didn't, thicken or strengthen enough with time. And so if they go onto if they go play a sport and they play basketball or soccer and they are in the middle of strenuous activity, they often suffer a spontaneous pneumothorax. So try to remember that as you read your exam questions. If they're describing something of that nature, you're probably looking at a spontaneous pneumo question. As you're managing someone with a spontaneous pneumo, we just want to give oxygen to maintain an SpO2 of 94% or greater. If you do have to use positive pressure ventilations, then we want to use as little of it as possible. Here we do not want to use CPAP because if we are continuously putting positive pressure into the lung and the lung has a hole in it, well then that air is going to escape from that hole into the pleural space, and now you're going to deal with a more severe pneumothorax or a tension pneumothorax. All right, this slide is on hyperventilation syndrome, which is not something I don't recall seeing on the exam. NREMT might ask you a couple questions on this, but this is typically your anxiety attacks when your patients are so emotionally upset or excited, or it's a panic attack that their breathing is faster and deeper than normal. And so they're breathing too much carbon dioxide out, and they may experience muscle cramps in the feet or the hands. For these patients, you don't want to withhold oxygen, but the goal here is just to try to calm them down. I think when it comes to diagnosing or having a field impression of hyperventilation syndrome, the biggest worry here is that rescuers will assume that it's just an anxiety attack or a panic attack, and that we default to the hyperventilation syndrome as opposed to something more severe. So I feel like, we want to kind of keep this in as the very last, item in our flashcards, right? Like if you are trying to ascertain what is wrong with your patient, you should be ruling everything else out before you go to the fact that the patient is having an anxiety attack. So, read the situation, read the room, but try not to assume that it's an anxiety attack early. When we say, calm the patient down, obviously you don't want to just sit there and tell them to calm down or that whatever they're dealing with is not a big deal. Most of the times it's just better to remove the patient from the situation, or if there's a lot of rescuers and other people around, try to isolate them, get them into an environment where they can be secluded from most everyone else. And again, calm them down, reassure them that everything's going to be all right. Just be a friend in those situations. And if they do need oxygen, again, do not withhold it. Next up is epiglottitis. So epiglottitis is the infection of the epiglottis, and we say that males and smokers are more commonly affected, but I think this condition is more so seen in pediatric patients, or at least most questions are geared towards pediatric patients when we describe epiglottitis. As a quick review, your epiglottis is that structure that folds over the trachea to prevent any food or water from going down the wrong pipe. And as this becomes inflamed, you can see from the image that there is now potential risk of an airway occlusion, because if it gets too big, then it's going to also occlude the opening to the trachea. When you're assessing your patient for epiglottitis, it's mostly due to a history of an upper respiratory infection. So it's usually like a viral infection. If you have a patient with stridor, like they're breathing in and you hear that sharp sound, that high-pitched sound, then, put two and two together, you might suspect epiglottitis. When you're managing a patient with epiglottitis, the main goal here is you do not want to agitate it anymore. So don't inspect the airway. Don't do anything that could, cause any irritation, because any irritation to that structure is going to cause more inflammation. And if we have more inflammation, then you have the potential of a closed off airway. Since a lot of questions like to gear this towards a pediatric patient or a very young pediatric patient, we really want to highlight that you want to keep the patient calm and comfortable. So some strategies here is, don't put any mask on the kid's face if you can help it. Remember, we can use the blow-by oxygen administration. If you can have a parent or guardian do that instead of you holding it, that would be even better. And when you're transporting the patient, again, keep them with someone that they're comfortable with. We don't want these patients to cry and potentially agitate the inflammation. Next, we'll talk about pertussis, which is another condition caused by virus, and it is characterized by what we call, whooping cough. And so as the patient coughs, you'll hear a very distinctive, they really do sound like they're just whooping. Um, and again, this typically affects your younger population, but, other complications that could arise is you could lead to, pneumonia, or if the patient isn't breathing very well, then they'll become hypoxic and cyanotic. So again, I think your biggest takeaway is that distinctive cough. While managing the patient, again, make sure that their SpO2 is above 94%. Supply oxygen if you have to. You might want to put a surgical mask on them to prevent the spread of this disease, since it is known to be quite contagious. And then, just comfortably transport them to the hospital. All right, cystic fibrosis is a hereditary disease. So your patients with cystic fibrosis are usually born with it. Actually, they're always born with it, and they should know if they have cystic fibrosis. With this condition, we don't really see a very long expected or we don't see a life expectancy past the age of 30. And this is due to something was wrong with their chlorine channels where it causes their mucus to become especially thick. And so as it's so thick, they can't cough or get it out enough, and that's going to trap a lot of debris, a lot of bacteria, and it's going to lead to repeated infections throughout their life. And so as they get older, it just causes wear and tear on their system to the point that they can no longer compensate or sustain it anymore. Again, with new recent medications and treatments, I think we're seeing the life expectancy stretch a lot longer than it used to be. But you know, all of this is just, managing your patient with comfort measures. So obviously, if your patient has some kind of poisonous exposure where they're inhaling a toxin, that could obviously lead to hypoxia. And, depending on what toxin they are inhaling, it could lead to upper airway swelling. It could lead to damaging of the alveoli. It could have effects on how well your red blood cells pick up the oxygen. So there's various different factors here. We're not going to really highlight, how to manage all the different poisonous exposures. I think we cover that more so in Module 7. But here on this slide for this exam, we're just going to highlight, your personal safety. So make sure that you are exercising great caution when entering the scene for potential toxic inhalation, especially if there's, more than one patient. The only management we will highlight is obviously to limit exposure to the toxin and then just go over your ABCs, right? If their airway isn't open, then go ahead and open it. Provide oxygen as needed or positive pressure ventilations if they're not moving air well. And, lastly, we do want to gather information about the poison so we know what we're treating and dealing with at the hospital. These last few slides will kind of talk about your general virus infections, so like your colds, your flus. Um, these are typically mild, but sometimes you can have an infection that becomes severe. And again, I'm going to sound like a broken record, but you are just treating these patients with comfort measures. Uh, Again, comfort measures, maintaining an SpO2 of 94% or greater. If we have to ventilate them, then ventilate them. So again, as you read through these questions, just pay attention to those key words of what we're describing. If we're saying that your patient is in respiratory failure due to poor tidal volume, inadequate chest rise and fall, shallow breathing, or diminished or absent lung sounds, then you need to ventilate your patient. If we are saying that the patient is able to breathe, like it's labored, but they are moving air well and their SpO2 is kind of low, then you want to consider a non-rebreather instead. In the next couple slides, we're just highlighting pediatric patients, and we are going to highlight this fact that respiratory failure is the most common cause of respiratory arrest and therefore cardiac arrest in your pediatric patients. So, if we recall uh, our AED scenario where we have a BLS team, we're switching from 15 to 2, from 30 to 2 down to 15 to 2. And most of our assessment and treatment plans when it comes to kids is to aggressively manage their airway. Recall that your pediatric patients, when they start to decompensate, they decompensate quickly. So again, we're all about restoring their oxygen to where it needs to be, opening their airway, because these kids, they haven't had many years to develop heart disease or liver disease or whatever else. If they are undergoing a medical issue, it's typically due to their airway. We want to make sure that we are able to recognize early signs and symptoms for a pediatric patient, just because, again, when we know that the patient it starts to look bad, then a very bad result is going to follow up very quickly. So we want to see if your patient has any signs of nasal flaring or if they're having increased use of accessory muscles. Sometimes they'll assume the tripod position, and if you can see these signs early instead of ignoring it, you're more than likely to prevent the child from becoming a lot worse. When you know that your patient is going into respiratory failure, then, as you feel or palpate their heart rate, it might be slowing down, their blood pressure is going to drop, they're going to appear like they're breathing very irregularly, you might have loss of muscle tone. They may not regard you anymore or cry, or they will be very lethargic. And so if you have signs of this, respiratory failure, then you really need to act aggressively in the management of this patient. I threw this slide in here just to kind of re-emphasize that if you are dealing with a pediatric patient, that you may not want to hold the mask onto their face directly. The parent might be able to do so, and if the child can't tolerate it, then just go ahead and do that blow-by oxygenation that we talked about earlier. When it comes to geriatric patients, they have a lot of different medical conditions that could cause respiratory distress, and their respiratory function itself may already be diminished. So, when it comes to elderly patients, again, there's no real difference in how you're going to manage them. Just, be aware that if they are in respiratory distress, it can proceed very quickly into failure since they tend to decompensate rapidly as well. All right, I know this video is already getting kind of long, but cardiovascular emergencies just kind of goes hand in hand with respiratory emergencies, so I hope you guys are still with me and able to power through for the rest of it. Again, I'm not going to sit here and try to give too much A&P on the heart. You just need to remember that it's a pump to pump blood throughout the body. We have to remember that the left ventricle is what pumps to the rest of the body, and we really want to highlight the importance of blood flow through the heart. So I highly recommend that you do review blood flow through the heart if you remember it from Module 2, or ask your instructor to kind of sit down with you and help you walk through the steps again. This is very important into understanding the pathophysiology of some of the other conditions we're going to talk about. And, there are a couple test questions that will once again ask you to trace a drop of blood. Where is it going to be, if it starts in this chamber, and then where does it go next, et cetera, et cetera. The biggest takeaway from this slide is that your heart muscle is perfused by the coronary arteries. And so if you have any occlusion of those coronary arteries, then you're going to deprive the heart of oxygen. And so this is when you're going to, this is basically what we're describing as a heart attack. Whenever you are dealing with a cardiac patient, we want to say that time is critical, so early recognition is key, and we want to get these patients, everything you do in the field will help extend the time for these patients, but ultimately the main advantage is having the EMT transport the patient to the correct facility, which is, for your exam purposes, you need to know what a PCI facility is, or transport to a facility with percutaneous coronary intervention. And what these facilities are able to do is they are able to, you know, they're able to surgically remove any clots from the coronary arteries or take measures to circumvent blood flow so that everything restores to normal. So some cardiac syndromes we have to consider is arteriosclerosis and atherosclerosis. So arteriosclerosis is just the hardening of the arteries where they become more stiff and less elastic over time. Atherosclerosis is a form of arteriosclerosis that is, due to inflammation, and it's often due to the buildup of plaques within the blood, within the arteries themselves. And so that buildup of plaque is going to narrow the reduction of blood flow through the heart or through the body. So when we talk about acute coronary syndrome, this is a significant disease and significant cause of death in the United States. Most of its symptoms can be caused by, atherosclerosis or arteriosclerosis, where those narrowed arteries can lead to myocardial ischemia. And so breaking that term down, you have heart muscle that is becoming ischemic, or it's not getting enough oxygen. With a patient experiencing acute coronary syndrome, they're more than likely going to have some kind of chest discomfort or chest pain. And so when we talk about angina pectoris, this is when you have reduced oxygen delivered to that heart muscle and it is relieved with rest and nitroglycerin. Recall that nitroglycerin is a vasodilator to kind of help open up those blood vessels, which will hopefully open up perfusion to the heart muscle. This slide just has an image to demonstrate that as you have narrowing of those arteries, those coronary arteries, it'll lead to a blockage, and then you're going to have ischemic heart muscle that is, distal to the blockage. Something to remember is that females in general may develop atypical signs of angina pectoris. So, where the patient is suffering from a potential heart attack, your female patients and even your geriatric patients may not have your typical signs and symptoms. So, whereas everyone else is complaining of chest pain, they're going to present with other findings. And these non-classical findings typically include neck ache, pressure in the chest, tingling in the fingers, unexplained fatigue or weight gain, some insomnia. And before all you girls are sitting there thinking like, oh my gosh, I'm having acute coronary syndrome right now. It's not to say that you're always experiencing this. We're just wanting to highlight that females in general will have an atypical finding, and therefore we can't just write off patients that are calling 911 for these reasons. When caring for a patient experiencing chest pain, we want to do the usual managing their ABCs, but we also want to make sure that their oxygen stays above 94%, and we want to assist the patient with nitroglycerin if their systolic blood pressure is above 90. Also keep in mind other contraindications of nitroglycerin, such as use of a drug for erectile dysfunction or if they're allergic to nitro. We also want to administer aspirin if they are not contraindicated. So if they don't have an allergy, we just want to make sure that we administer aspirin up to 324 milligrams. When we talk about acute myocardial infarction, this is our very definition of a heart attack. This occurs when a plaque ruptures or a thrombus forms within those coronary blood vessels. And so we're talking about an occlusion where you have inadequate perfusion causing heart muscle to die. So with the previous example, those vessels may be narrowed and therefore it is reducing oxygen to the heart muscle. And in these situations, we're talking about the occlusion of oxygen to the heart muscle to where the muscle is actually dying now. As the patient becomes more ischemic, you might see cardiac dysrhythmias, or even your patient goes into sudden cardiac arrest. This slide kind of goes over the differences on how to distinguish angina pectoris from myocardial infarct. Honestly, the exam, I'm not going to make you guys do that. This is more so for you to review on your own time if you think that the NREMT is going to become that specific. But the biggest takeaway is you want to treat all cases of chest pain as cardiac emergencies, as the two are very similar, and it's your heart. So if you have any issues pertaining to the heart, we don't want to lollygag on scene with it. Continuing on about the acute myocardial infarct, we want to make sure that we have an AED available since there is a risk for potential cardiac arrest. We want to administer oxygen as needed to maintain an SpO2 above 94%. Administer nitro and aspirin just the same for all chest pains, and as well, manage their airway and breathing. We should notify the hospitals as soon as we can to let them know that we're coming in. This is gonna allow faster treatments for the patient as soon as they walk through the door. Next to, I'm talking about aortic aneurysm or dissection. So here for the exam, you just need to be able to define what is an aortic aneurysm. And an aneurysm is basically when you have a weakened area of the wall that is dilated. And as it weakens and balloons out, it could potentially rupture, and this will lead to, fatal internal bleeding. For those of you having trouble visualizing what I just described, again, it is a weakened section of the wall in the aorta that is going to expand, and if it's not treated or managed, it'll eventually burst. When we talk about aortic dissection, dissection is when there's a tear in the inside wall of the aorta. And so as blood pumps through that aorta, it starts to separate or gets in between the tear, making it worse. And so when it's often occurring, patients describe it as a severe, sharp, tearing pain that goes through to their back, or I guess it could also involve their flank or arm. And so here's another slide just to kind of give you guys a visual representation of what I'm talking about. The dissection there, you have a tear in the lining, and as blood keeps pumping through, it kind of gets in between that tear, making it worse and almost, ripping the artery apart. So in order to suspect your patient is having an aortic aneurysm or dissection, for an aneurysm, if you palpate a pulsating mass in their abdomen, for example, then you probably don't want to touch it again and just recognize that you're dealing with a potential aneurysm. For the dissection, again, if they describe that tearing pain through their back and their chest, you kind of also might want to be cautious that this is a potential dissection. So only thing you can do is try to get to a hospital as quickly and safely as possible. Try not to hit too many bumps on the road. These patients do require immediate surgery. You definitely don't want to administer aspirin in this case because if there is any tearing or if anything is about to burst, you want your platelets to be able to work. I feel like I'm backtracking a little bit on this slide, but we want to kind of highlight the dangers of administering too much oxygen in acute coronary syndrome. And this is to highlight on your exams if you are facing one of those multiple questions on like which treatments are appropriate. If your patient has an SpO2 above 94% already, we don't necessarily need to give them more oxygen. It was previously thought that oxygen in all situations was beneficial, but lately we've had more recent research that shows that giving too much oxygen, to above, to up to 100% will set your patient up for what we call reperfusion injury. And all that means is that as we restore perfusion to the damaged or dying cells, if too much oxygen gets in those cells, we're going to create free radicals. And those free radicals are going to just cause even more damage. So now all we do is just keep them above 94%. If they're already above 94, we can leave the oxygen off. Okay, so heart failure or congestive heart failure occurs when the ventricle can't adequately eject blood. And your most acute examples of heart failure is when it's caused by a heart attack, right? So like if a lot of heart muscle dies, then it's not going to be able to pump effectively. But there are other issues like heart valve problems, chronic hypertension, a pulmonary embolism, or any other cardiac rhythm disturbances. So this is where understanding blood flow through the heart will become beneficial. Um, we typically refer to left-sided heart failure when we talk about congestive heart failure. And you have to think about if the left ventricle is unable to pump blood forward, then it's going to cause a traffic jam or a backup of blood. And so if the blood backs up in the left atrium, which increases pressure in the pulmonary veins, you now have that pulmonary edema that we talked about in chapter 16. So recall that as that pressure in the pulmonary veins increase, you're going to have fluids leaking into the space and then possibly into the alveoli as well, and that's going to impair gas exchange. And so just to remind you guys, as that fluid fills the alveoli, you're going to start to hear that crackle lung sounds. We usually talk about left-sided heart failure, but right-sided heart failure can occur as well. And this is caused usually by failure of the left side or COPD. Signs of right-sided heart failure will be peripheral edema. So if you recall, blood returns to the heart from to the right atrium and into the right ventricle. So the right ventricle is failing to pump blood forward, then you can have a backup in the right atrium and then into the body. And we're going to see this swelling or edema in the most peripheral portions, such as the wrists, the feet, ankles and legs. And you know, whenever you have failure to pump blood, then cardiogenic shock can occur because this is a pump failure now. If a question is trying to describe left ventricular hypertrophy, then we need to break down that term that this is abnormal or too much growth of the left ventricle. And so for this slide was, the only image I could use to depict this well enough. But on the left side, you have normal heart, normal output, normal blood pressure. And on the right side, you've had years and years of, enlargement of the left ventricle. And so a lot of students ask, well, how does the left ventricle get so big? And usually it's built up from pumping against chronic high blood pressure. So if it's pumping against a higher resistance over a long time, then that muscle is going to start to thicken and get bigger, just like if you were training in the gym, right? So for most other, skeletal muscle, that's fine. That's probably desired. But in cardiac muscle, that increase in mass is going to reduce the space inside the ventricle. And so with that reduction of space inside the ventricle, you're not getting enough preload, and therefore your cardiac output will go down, and therefore your blood pressure will go down. And this is, just another system of heart failure. So this table is again just kind of comparing left-sided versus right-sided heart failure. If you have left-sided heart failure, you're going to hear that crackles. You're going to have, possibly a normal to high systolic blood pressure. And if it's only right-sided heart failure, then you shouldn't have anything backing up into the lungs, but you might have a low systolic blood pressure, and you're going to see peripheral edema in the ankles, feet, or even in the jugular veins. Those of you that have never witnessed, peripheral edema, here's just a slide just to kind of give you an image to see what it could potentially look like. By now in the classroom, we probably mentioned JVD or jugular vein distension quite often. Here's just another image if you haven't looked one up yourself already of how JVD will appear. And we'll see that vein is engorged and just bulging out of the neck there. Keep in mind, if you do see JVD, this is a very late sign of congestive heart failure. So now that we've kind of thoroughly discussed what heart failure is, how do we treat it? Recall that the most common cause of acute heart failure is an acute MI or heart attack. So we treat it just as it is a heart attack. We want to give supplemental oxygen to stay above 94%. And because the left-sided heart failure will present with pulmonary edema, that swelling in the lungs leading to the crackles lung sounds, then you really want to highly consider the need for CPAP. If it is caused by a heart attack, we want to allow the use of nitroglycerin and aspirin so that we can vasodilate the blood vessels as well as prevent the clots from getting any bigger if there are any. And for this last slide, we are just reviewing cardiac arrest again. Recall that cardiac arrest is the cessation of the heart to effectively pump blood to where you cannot feel a pulse. If you have a patient that goes into cardiac arrest, then we need to remember to start CPR and just follow our guidelines from the AHA. As a final note, we are going to review nitroglycerin since it is very prominent in all your cardiac emergencies. Just remember that it is a potent vasodilator, and as it vasodilates, we are increasing blood flow through the arteries of the heart. So this will hopefully reduce the workload of the heart by increasing the, how much oxygen is being delivered. We also kind of decrease the pressure in the vessels surrounding the heart, and that way the heart may not have to pump as hard, and it's not going to have as much resistance. Remember that EMTs are able to assist a patient with their own nitroglycerin, whether it's tablet or spray, and you can give up to 3 doses every 3 to 5 minutes. We are going to review some contraindications that nitro should not be given to anyone with a systolic blood pressure less than 90, and we want to make sure that the patient hasn't taken any drugs for erectile dysfunction. If you don't recall, any drugs for erectile dysfunction is usually a vasodilator in itself, so if we apply nitroglycerin on top of it, it's like doubling the dose of a vasodilator. We're going to just cap this off by recalling some of your special populations and their considerations. Pediatrics, again, they haven't had a long, difficult life to accumulate a bunch of cardiac issues. If there are any, then it's congenital, meaning that they were born with it, and it's not due to acute coronary syndrome. If your patient is in cardiac arrest and they're pediatric, then we need to assume, or we should assume, that it's due to some kind of airway compromise or respiratory failure. As for your geriatric patients, they're on the opposite end of that, right? They've had a long life of, whether it's bad diets or they're just getting too old that things aren't working as well as it used to, and these patients are going to represent the highest number of patients that are experiencing some form of acute coronary syndrome. So that's just there for you guys to keep a perspective. Hopefully you guys are still trudging along in your studies. We got one more video to go.